Hello everyone, this is Tilak Pasala. I'm one of the Interventional Cardiology Fellows at University of Utah. I'm very excited to speak to Dr. Kodali here. As you know, Dr. Kodali is very well known. He's from Colombia. I have a few questions for him. Welcome, Dr. Kodali.
Thank you so much. Thanks for having me. It's wonderful. Thank you.
That's great. So I have a few questions for you. We're very excited to know about the Partner 2A data that was presented yesterday in ACC. We would like to know what is your perspective on it.
I think it's great for the field of transcatheter valve. I think it's going to move the field forward. Early on it was sort of saying, is this technology feasible? Is it a good alternative to surgery? I think now the questions are, is this a better option for patients? I think the trial yesterday, for the primary endpoint, it was non-inferior to surgery. But I think in terms of how we use the technology now for patients that can go from the transfemoral route, the data suggests superiority. Again, it was not powered for that, but it was a pre-specified subgroup. And I think, as devices have gotten smaller, at our site anecdotally, 95%, 90% are transfemoral. So I think for those patients, this may be the preferred alternative, especially and to be fair, it's in the group that was studied in this trial. These are patients over the age of 80 that had some risk factors. But in those patients, I think it's an option, and the field's going to move forward. And today we're going to have the SAPIEN 3 results 1 year, and that will hopefully continue to move the field forward. And there's an interesting presentation today. Also, John Carroll is going to talk about impact of volumes on outcomes. And so I think those three are sort of, from a TAVR perspective, are sort of the big data releases. Evolut has presented its U.S. registry, which again showed good outcomes. Even in high-risk patients, low mortalities, low stroke, reproducible results. And the technology has gotten to the point where the devices are very reproducible in terms of the outcomes they're getting.
So correlated to that question, given the Partner 2A data now in intermediate risk patients, would you be changing your practice, and would you foresee guidelines changing soon as well?
The changing practice, to be honest, has already happened. If you look in Europe, for example, they already acted if this was the data already. Even the U.S., the mean STS in this trial was around 5.8. Even in the U.S., the TVT registry data, a lot of clinicians have changed their practice, and they're because the technology is safe. What we don't have the question of is it long-term durability. Right. But the question of durability is a tough one. In an 85-year-old, you probably don't need 12 and 15-year durability. Average survival for an 85-year-old male is 6 years. So, I think people have taken their interpretation of the data, and practice has changed. Now we have to wait for CMS and FDA to approve this for intermediate risk patients before we truly treat intermediate risk patients. But I think it does change our practice, and I think it's not an alternative. And I think it is an alternative, but it's also not only is an alternative, it may be the preferred therapy.
I know that TAVR is pretty evolved now, and we're refining it. What do you see some of the challenges that will still exist, at least in the aortic valve space? Now, a lot of interest in mitral valve, but what do you see most challenges here?
I think in the aortic space, the issue of leaflet thrombosis that was raised by Raj Makkar's analysis last year is an important one. I think we have to keep that in perspective, though. That was an imaging finding, and I think we need to investigate it further. But associating it to clinical events, anticoagulating every patient, there's no data to support that yet. I agree that it's an important finding, and it's a finding not only for transcatheter valves but for surgical valves. What is the true incidence? What is its impact? How should we treat patients? These are questions that are going to need to be answered, and there are trials that are going to answer it. There are trials with the NOACs. AFib or no AFib, looking at the patients and maybe rather than aspirin and Plavix, whether that's the preferred therapy. And I think we're going to get a lot more data with these upcoming trials to answer some of those questions. The issue of embolic protection. We'll have data hopefully later this year from the Sentinel trial looking at embolic protection with the Claret filter system. I think the devices themselves, there are 2 devices in trials in the U.S. right now with Direct Flow Medical and Reprise, and Reprise has finished their enrollment. We're going to have access to probably more devices in the near future. And it's sort of the outcomes have gotten better. When you look at the TVT mortalities in the TVT registry, they've gotten better each year. And part of that is a shared learning. We've learned how to better select patients. Part of that is device improvement. And I think those are we need to continue to refine it and optimize the results, not only from the procedural aspect, but from the post-procedural care. The mitral side is a whole nother thing. It's right. I mean, it's in its infancy. I mean, it's important to keep in mind that the first transcatheter valve was in 2002. Right. It's been years, and it's been a relatively rapid iteration. The mitral technology is still in its infancy. There's a lot of issues of, if we think thrombosis is a problem in the aortic space, it's going to be an even bigger problem potentially in the mitral space with the low flow states and a lot of metal sitting there. The issues of anchoring, of variability, LVOT obstruction, hemodynamics. There's just a lot of unanswered questions, and whether replacement or repair with the mitral clip is going to be the better option is unclear.
Thank you very much, Dr. Kodali, for spending time with us.